Thank you, everyone. We welcome you all to the pediatric session, and for the first talk in the pediatric session, I'd like to invite Dr. Yusuf Al-Halak, and the topic would be defining UTI, where do we stand?
Thank you very much. Dear colleagues and friends, good morning. First, I would like to thank the organizing committee for inviting me to participate in this prestigious conference. And actually, Arab Association of Urology and Kuwaiti Urological Association, they pay a very big efforts to do such a great conference. Actually, I've been asked to create a miracle by talking about UTI within 10 minutes. So I'm going to do such only an overview about this subject. Now, the index of my talk is going to be about the definition, epidemiology, pathogenesis, causative organisms, and classification systems, diagnosis, treatment, and recommendation and prevention. So according to the American Urological Association, the definition of UTI or urinary tract infection is a combination of pathogens within the urinary system and symptoms and or inflammatory response to pathogens requiring treatment. UTI represent the most common bacterial infections in children, and in neonatal age group, the UTI are more predominant in the male genital. Infections caused by other organisms other than E. coli are more frequent in this age group. There is a high risk of urosepsis also in this age group, and in infants, the prevalence of UTI is about 7.8%. Infants presenting with fever in the first 3 months of life, UTIs were present in 7.5% in girls, 2.4% of circumcised boys, and 20% of uncircumcised boys. The incidence of boys, the incidence for boys is highest during the first 6 months of life. It's about 5%, and decreases with the age to around 2% till the age of 6 years old. The other one, for the girls, it's the other way around. The UTI are less common during the first 6 months of life. It's about 2%, and the incidence increase with age to around 11% for the age till 6 years old. All of you are aware about the pathogenesis of UTI, and as you know that the UTI starting either hematogenous or ascending infection, and the ascending of the pathogen colonize the paraurethral area are usually ascend to the urothelium in the bladder, where by the aid of fimbria, the attachment, adherence, and penetration, replication of the bacteria leading to make some sort of biofilm and colonization. And this will ascend to the upper tract by the bacterial toxins, which may play a role by inhibiting the peristalsis, which reduce the flow of urine, and you know this is a very important factor in preventing UTI. If reaching the upper urinary tract, it leads to infection of the parenchyma, causing pyelonephritis, and if the inflammatory cascade continue, tubular obstruction and damage occur, which may lead to interstitial nephritis, which causing acute kidney injury. As you know, the causative organisms could be because of bacteria like gram-negative bacilli, gram-positive cocci, and if there is a UTI without identifying any bacteria by culture and sensitivity, we have to put in our mind that it could be resulting from virus, fungi, or parasites. The most common bacteria causing UTI usually, as you know, that the E. coli, which represent about 65% of the pathogens, and it's followed by the Proteus, Klebsiella, and Pseudomonas, and other bacteria. There are some risk factors which may precipitate in causing the UTI, like alteration in the flora, and you know, using of antibiotics sometimes leading to some alteration in the periurethral flora, which may disturb the urinary tract, a natural defense against colonization. Some anatomical anomalies may play a role, like VOR, as you know, and the epidemiological survey have shown that between 21 to 57% of children who have had bacteriuria are subsequently found to have VOR. Bladder dysfunction is also important role in precipitating the UTI. And as you know, when there is a voiding dysfunction, there will be a high post-voiding residual volume, which may causing the UTI. And in turn, this will lead to some sort of change in the bladder sensation, which can cause further voiding dysfunction. To break this vicious circuit is very important to prevent UTI in the future. Constipation is very important and this needs to be treated because treatment of constipation will result in decreased frequency of urinary infections. Circumcision is very vital. According to the American Academy of Pediatrics, it's stated that circumcision can reduce the risk of UTI. And shown that during the first year of life, the rate of UTI was 2% in uncircumcised boys versus 0.2% in circumcised boys. And in febrile boys younger than 3 months, UTI was present in 2.4% of circumcised boy and in 20% of uncircumcised boy. Classification of UTI, there is a different classification systems. It could be classified according to the site, lower or upper urinary tract infection, or according to the severity, whether it is mild or severe, or it could be classified according to the episode, whether it is a first or UTI or persistent or recurrent or breakthrough UTI. The first UTI may be a sign of anatomical anomalies, and anatomical evaluation is recommended. Recurrent infections can be divided into unresolved UTI or persistent UTI. Unresolved UTI is applied to those patients who are initially having a therapy and it was inadequate for elimination of bacterial growth in the urinary tract, while persistent infection is applied to those patients who have a re-emergence of bacteria from a site within the urinary tract coming from a nidus for persistent infection that cannot be eradicated. Breakthrough infection is applied to those patients who are already on antibacterial prophylaxis and is usually caused by resistant bacteria or non-compliant parents or if there is any severe urogenital anomaly. Reinfection is usually for those patients. Each episode of infection can be caused by a variety of a new infecting organism, unlike that of bacterial persistence. The UTI could be symptomatic or asymptomatic, and the symptomatic could be typical or atypical. Last classification is according to the complexity, if it is a complicated or uncomplicated UTI. So if we face a febrile patient with clinical symptoms, first thing we should do is to rule out the presence of UTI. So we have to examine him, may send him for a blood test, urine analysis. If it is negative, then we are dealing with other cause other than UTI. If it is positive, then it's very crucial to send the patient for culture and start the antibacterial antibiotic treatment according to the antimicrobial stewardship strategy. And then we need to send those patients to renal and bladder ultrasound. If the ultrasound finding was normal, then we have to classify them whether the cause of UTI is E. coli or non-E. coli. Because if it is non-E. coli, we have to proceed directly to do evaluation to exclude, by imaging to exclude the VUR. And if it is E. coli infection, then we need also to classify them whether they are infants or children. Because if they are infants, we have to go again to send the patient for imaging to rule out the presence of VUR. If they are children more than 12 months, then we need to treat them. If there is any recurrence, then we need to exclude on both pathways the presence of bladder bowel dysfunction. In case that there is a positive finding by ultrasound, like some abnormal findings like dilatation, abscess formation, obstruction, then we consider this as a complicated UTI, and close monitoring with intravenous antibiotics should be given. If there is a response and if there is no response, then we need to make some sort of urinary derivation like fixation of JJ catheter or nephrostomy. And if there is a good response, then after resolving of the UTI, we need to send the patient for assessment also by imaging to exclude VUR. Do we need to put every patient on antibiotic prophylaxis? Actually, there is some recommendation and indication, like those patients with febrile UTI below 1 year of age, and if there is any complicated UTI in children below 5 years old, and if the patient has VUR, and this is also according to the age, grade, and presentation. If we have a frequent febrile UTI, which the definition is 3 or more episodes of UTI per year, or 2 episodes of UTI within the last 6 months. And also it's recommended for those patients with urethral instrumentation. Prophylaxis, antibiotic prophylaxis, it's not advised, not recommended for those patients with the urinary tract obstruction, those patients having urolithiasis or a neurogenic bladder, and those patients on CIC. So the route of antibiotics is either oral for those non-toxic patients, and for simple cystitis can be given for 4 days courses. And in cases where there is a toxic appearance patient, we need more aggressive treatment, like using parenteral fluid and antibiotic. And we should continue using the parenteral antibiotic for 24 hours after the patient being fever-free, and then switch on to oral antibiotics for 10 to 14 days. Do we need to hospitalize patients? Yes, there is some indication for hospitalization. It's indicated for those patients who are toxic or septic, patients with the signs of urinary obstruction or significant underlying disease, patients unable to tolerate adequate oral fluid or medications, infants younger than 2 months with a febrile UTI, and finally, all patients younger than 1 month with suspected UTI, even if not febrile. The antibiotic chosen, as usually the 3rd generation cephalosporin could be used, but in case there is any sensitivity, we can change to aminoglycoside like gentamicin if the renal function is normal. Actually, we have to put in our mind always the urosepsis, because this condition is very serious and need to be diagnosed early stage, because many of those patients can move from almost harmless state to severe sepsis in a very short time. Generally, sepsis because of UTI have a lower mortality than that from other sources. So we have to put in
Dr.
our
Al,
mind,
if you could
follow up. Yes. The vital signs was the heart rate, temperature, respiratory rate, blood pressure, and pulse pressure. These are pediatric vital signs which should be present in the intensive care unit. The severity of sepsis should be assessed by SIRS, the presence of abnormal temperature, abnormal leukocyte, tachycardia, or tachypnea. If 2 of these parameters are there, we have to suspect sepsis. There are some factors that lead to poor outcome, like delayed recognition of sepsis, lack of timely escalation for intravenous access, delayed in IV fluid resuscitation, inadequate monitoring and pathways for escalating care, gaps in communication within teams, hands-off transfers. Regarding the recurrent UTI, we should identify always the predisposing factor. We can add prophylaxis antibiotic for them, and adding in the treatment a probiotic therapy and cranberry therapy. So in the long-term outcome, if there is any upper urinary tract infection, that can be resulting in renal scarring, especially it is highest risk in children less than 2 years, and this may end with a renal insufficiency and end-stage renal disease associated with hypertension. So what is the future directions for pediatric UTI? The vision should be directed to a rapid UTI detection, non-invasive imaging for VUR, genetic profile for UTI scarring risk, and urinary proteomes evaluation for important parameters like UTI risk, renal inflammation or scars. Multiple antibiotic drug resistance are global health issue. Further perspective to promote the development and translation of nano antibiotics as alternative against multiple drug-resistant pathogens to traditional antibiotics-based approach. Finally, we need more prospective studies regarding the different age pediatric UTI. Thank you very much.
Yes, thank you, Dr. Youssef. So the next speaker will be Dr. Daidan Shamri, and his talk will be about follow-up post-pyeloplasty, nuclear scans versus ultrasound.
Hi, Hi. So sorry, the talk, we've had a recent change in subject. It's going to be about febrile UTIs and reflux, the latest updates and treatment strategies. So I have no disclosures. Today I'll be speaking about the predisposition to UTIs, the relation with VUR, VUR and the presence of renal injury dysplasia, VUR diagnosis, prophylaxis, duration of prophylaxis, and I'll try to link them all up together. So on the right side, or sorry, on your left side, we see that pyelonephritis and VUR, they have an interchangeable connection where VUR is known to cause pyelonephritis. However, some studies have shown that infection by itself can induce VUR. The other side of the screen is what happens after recurrent or after a single UTI, where renal damage happens, CKD, and potential of ESRD. The whole goal of a pediatric urologist or any physician managing patients with VUR, recurrent UTIs, is to prevent the progression to renal damage. I always like to talk about the recent American Academy of Pediatric guidelines when it comes to UTIs, as I believe it's very important. So this is the latest update. The take-home message is, number one, diagnosis requires a positive urine culture that needs to be obtained correctly. So if he's a 1-month-old boy, a catheter sample is required. In a non-septic patient, oral treatment is as effective as IV. VCUG is not routinely recommended after the first febrile UTI, and there is a special emphasis on not needing to repeat a urine culture in asymptomatic patients. Asymptomatic patients do not need us to repeat a urine culture every time we see them in clinic. So, VUR causes infection. Infection causes VUR. It has been seen, of course, we all know that stasis of urine can potentiate a UTI, and this is what happens in VUR. However, on the other hand, we do know as well from multiple studies now that UTIs themselves, they can actually damage and compromise the UVJ itself, hence contributing to the creation of a VUR. UTI-inducing VUR has been seen, has been proven in many experimental models, and this dates back to more than 30 years ago, where in piglets, they induced a UTI in a patient who did not have, or in a pig who did not have VUR. Subsequently, the piglet did develop a VUR. And they also saw that endotoxins did affect the trigone area, making it weaker and more susceptible to reflux. On the other hand, does VUR predispose to UTI? The very famous Professor Ransley, more than 40 years ago, in a pig model as well, induced reflux, and the pig was able to sustain a healthy short life without having any UTIs. This was also seen in the International Reflux Group, where some patients, although they were reimplanted, although the reflux completely disappeared, the predisposition, the biological predisposition to UTIs still existed. So this, and Dr. Ransley's challenge has never ever been challenged since then. So in the first part of this lecture, I think the summary is that UTI can definitely facilitate a VUR, which has been proven in models. VUR does not have a dominant role in causing UTIs. However, it does facilitate and can potentiate a UTI. So, other ways that the infection of bladder can cause reflux is all of the above, basically. It lowers compliance, elevates pressure, and all the things mentioned. And also, it's very important to speak about the other factors like constipation, bladder dysfunction. And some studies have also shown that in kids with UTIs, around 60 patients of them are actually somewhat constipated. So these are also important factors that I just wanted to talk about briefly. VUR and renal injury dysplasia. So the general understanding is that repeated infections cause scarring. However, we understand now that many patients that have reflux actually start from the beginning with a degree of renal dysplasia. And multiple DMSAs, few studies have shown that the higher the degree of reflux, the more the renal dysplasia present. That being said, there is also a concomitant. So the higher the VUR, the higher the renal scars, and more recurrent UTIs. And this has been shown actually in also the study of unilateral reflux. So clinically, to sum up, clinically significantly acute lesions can occur in the presence or in absence of reflux. However, renal scarring present on the MSA is more likely to happen with high-grade reflux. And high-grade reflux is 3 and above, basically dilating reflux. So this slide is just to talk, it's like a preparation for us to speak about the top-down approach and the bottom-up approach in diagnosing reflux. But basically saying that in a DMSA, photopenic areas can represent post-infection scarring and some renal dysplasia. Now, what is the difference between a top-down approach and a bottom-up approach? So a top-down approach starts in the acute phase. A nuclear scan in the acute phase. This DMSA can pick up or can rule out an acute pyelonephritis. If it picks up pyelonephritis, then the next step would be VCUG. On the other hand, the bottom-up approach is where we actually start with the VCUG and go up to a DMSA if the VCUG is positive. In the top-down approach, some don't even, in the top-down approach, you can see and understand that the problem is we can miss low-grade reflux. So this is another flow diagram speaking about the first UTI and how a DMSA in the top-down approach, if it picks up any problems, then a VCUG can pick up reflux, and subsequently we can treat reflux accordingly. The top-down approach basically speaks that low-grade reflux, even if we don't pick it up and we treat it without knowing it exists, does not need to be heavily investigated. Of course, if you pick up something acute on the DMSA, you need to repeat the DMSA a few months later to confirm the presence or an absence of a scar. So, which of the following statements is false regarding the DMSA scans? Basically, the DMSA is bound to the glomerular basement membrane, providing excellent cortical imaging, but slow excretion. So now the most important, for me, is the most important topic, antibiotic prophylaxis. Do we put patients on it? Do we not? So now we know that high-grade VUR can be associated with renal dysplasia, can be associated with a predisposition to UTIs. It's been shown many, many years ago that first, a low-dose prophylactic antibiotic can prevent UTIs from reoccurring. However, we do have conflicting opinions. Intervention, what's the rationale? If sterile urine is benign, why do we put them? Is it really effective? What about antibiotic resistance? What about compliance? Now, leaving a patient without any antibiotic prophylaxis can also be very scary given the burden of hospital admission. However, we do have patients who are circumcised, do not have any bladder bowel dysfunction, do not have a massive history of UTIs, have a normal ultrasound, normal DMSA, and have a low-grade reflux. Do these patients need to be on prophylaxis? That's the question I always ask. And again, the NICE and AAP guidelines they don't have a routine recommendation for prophylactic antibiotics. And as the previous lecture also mentioned, there is a specific population where prophylactic antibiotics would be encouraged. The International Reflux Study Data Group did show that in normal kidneys, if somebody has a UTI, the risk of them developing a new scar is around 12.5%. However, in a scarred kidney, the risk goes up fivefold to 62%. So, in their conclusion, they said that treating new infections is not a good option. We need to prevent them because, especially if a kidney is scarred and it develops another UTI, then the risk of them developing another scar becomes very, very high. So this supports using prophylaxis. However, again, just to look at the other side of the coin, prophylactic antibiotics do have lots of problems associated with them. Fecal flora become resistant to treatment antibiotic. And what I would say is, out of all these things, probiotics may have a moderate effect if used in conjunction with antibiotics. So I think the study that is mostly cited when it comes to prophylaxis is the RIVER trial. And they've actually did a randomized control trial weighing antibiotic prophylaxis leading to UTI prevention versus placebo. And they did see that there was a significant reduction in UTIs in patients under the antibiotic prophylaxis arm. However, they did show that renal scars did not change between prophylaxis group and placebo group, which can also predicate what we spoke about previously, that some patients are more prone biologically to develop UTIs and renal scarring. How long do we keep the antibiotics for? This is also a question of debate. Some keep it until toilet training, some keep it until the age of 1. However, this is a slide from the AUA guidelines. We see that VUR resolution is 20% a year, regardless of age. And we can see that grade 1 and 2, so non-dilating VUR, have a higher rate of resolution compared to grade 3 and above. So age is a crucial factor. The age of diagnosis of VUR is what allows you to basically work out the resolution curve. Traditionally, observation period is 5 years, and there is a reason why it's 5 years, because I'll come to that in a bit. Because, well, if it's 20% resolution a year, then you would expect that at 5 years, the majority of patients would have resolved. This is, I've put this question just to show you that, so the answer is C, but just to show you that the rate of resolution in low-grade non-dilating VUR is actually faster than dilating VUR. So, as we said, duration of prophylaxis can vary between 6 months to 2 years, and in many centers do differ in policy. And this explains why 5 years is the cutoff, because we see that post 5 years, it's very rare that new scars develop. Thank you very much, and sorry for going over time. Sorry, thank you.
Thank you. I would like to invite the next speaker, Dr. Walid Essa, on the topic non-invasive evaluation of the veter.
Thanks, Chairman, dear colleagues. In the following 10 minutes, we'll speak rapidly about how to non-invasively investigate children who watch themselves. It is a very common problem among children. At the age of 5 years old, nearly 1 out of 10 children suffers from wetting episodes. Using invasive methods to diagnose wetting in children creates tremendous amount of fear and anxiety, not only for the child, but also for the parents. The first item to non-invasively diagnose such a problem is taking a very good history. Don't hesitate to invest more time taking a very good history from the parents and even from the child if the child can express themselves. In history, we should concentrate on mainly 3 regions: the wetting episodes, the toilet and voiding habits, and the feeding habits. Regarding wetting episodes, we should know nearly all the data we need about when it started, how frequent it happens, how significant it is. It's just wetting, or the child has to change their underwear, and when it happens. Does it happen? Is it related to laughing, for anxiety, stress? And where? Sometimes it happens only at school or at home, and if it is associated with any other lower urinary tract symptoms. Regarding toilet habits and bowel habits, we should know when the child was toilet trained, and also how frequently they go to the toilet, and the amount and the volumes they are producing, and also we should investigate their bowel habits also, and try to ask a few questions to diagnose if there is any constipation or not. During feeding habits, we should know if the child drinks fluid well and eating a healthy fiber-containing diet. During history taking, we should also observe the posture of the child. Sometimes this gives us clue about their condition. There are many tools we use, auxiliary tools, during our clinic visit to fill the gaps in the history, like voiding diaries and toilet diaries, stool charts. In some places, they use questionnaires. There are nearly 7 valid questionnaires around. We don't usually use questionnaires. Questionnaires, we think they need more time, resources, and even staff to explain the questions for the family. We depend on taking standardized, systematic history taking. Proceeding to examination, you should exclude full bladder. In some thin patients, you can appreciate hard stool in the colon. When we move to local examination, first I look to the internal clothes of children. Sometimes there are wetting and spotting. You can appreciate how significant is the problem. And encopuresis can also be detected in the underwear. Looking for local causes of wetting, like phimosis, meatal stenosis, can be detected in male children. In female children, if you are lucky enough, you can find the ectopic ureter. And frequently, we see pooling of urine coming from the vagina in female children who are suffering from wetting episodes, especially after voiding. We never forget examining the back in children, looking for signs of occult spina bifida. Urine analysis can give us a clue about causes of wetting in children, like diabetes insipidus, diabetes mellitus, and the urinary tract infection. Moving to radiological investigation, ultrasound also can give us a hint about the cause, like duplication, which may be accompanied by ectopic ureter. Also, it will show us all the secondary changes due to dysfunctional voiding of the upper tract, and sometimes we can see vaginal pooling of urine in the vagina. Of course, rectal diameter can be measured to estimate the fecal load in children suffering from constipation. This is an image of a child with pooling of urine in the vagina just behind the bladder. Abdominal X-ray is frequently requested to appreciate the load of stool. It can be easily detected, but it's now debatable. Recent reviews, they recommend that the KUP is not correlated with the clinical symptoms anymore, and they prefer, this is just published this month in the Pediatric Urology, they prefer measuring the rectal diameter better than, or they prefer it than taking KUP and X-ray. KUP X-ray is requested frequently because it's easy and available, and we can get the result immediately. This is why it's still practiced until today. Also, we can detect spina bifida, which is not clinically important if you have a child with no neurological deficits apparent. Especially, it is found in nearly 10 to 20% of normal population. Uroflowmetry as a non-invasive procedure is the main standard non-invasive procedure in urology. In children, it's very important. This is our setting, actually. It's very important in children to know that it's not as easy as adult. You can't get results as easy as an adult because artifacts are very common. The child sometimes they miss the funnel. Sometimes they try to impress you and push hard. Sometimes they try to withhold. So there's a lot of artifacts. So usually it needs to repeat the Euroflow in children and teach them how to do it, especially if this is not a comfortable environment for them. Of course, Euroflow will give us very valuable data regarding how the children are voiding. This is a normal pill-shaped curve in the green square. Sometimes, if the child is suffering bladder instability, they have this tower-shaped curve. Staccato one in dysfunctional voiding, and in abdominal pattern, this is interrupted one if they have a hypoactive bladder. And this is plateau one is, of course, famous for obstruction. But this is not enough, and especially in children. Post-voiding residual is very important for us. And there are nomograms to detect which is the significant post-residual voiding we can consider regarding the age and regarding the percentage of the bladder volume. In this publication, and this is matching our practice, actually, post-voiding residual volume is the most important data we get from this study, which can affect our management plan. If you accompany the uroflowmetry with AMG, we can get more valuable data regarding the external sphincter. Meanwhile, taking AMG in children is also challenging. Placing the base in child is not comfortable for them. Sometimes they can be displaced because of the wetting. So we should be very careful also to obtain very good or clear results. In the green squares, this is a normal uroflowmetry with AMG. It is very clear that there is no activity in the pelvic floor muscle during voiding, and there is a lag between the cessation of the activity and the start of the voiding, not more than 4 seconds. This is the standard one. Of course, we can detect activity during voiding in dysfunctional voiding cases. Also, we can detect absence of lag here if the children are suffering a bladder instability or overactive bladder. Also, a prolonged lag if the child is suffering bladder neck dysfunction. Gathering all of this data will help us to establish a management plan for the children. And the management plan, of course, can go from just simple urotherapy, timed drinking and voiding, biofeedback, medical treatment like anticholinergics or alpha blockers if we have a problem with the bladder neck, up to CIC. And that's all. This is the whole lecture. Thanks.
The next speaker, Dr. Darius Bagley from Toronto. Management of hypospadias, active surveillance.
Thank you very much. I'd like to thank the organizers for the lovely invitation to visit you. This is my first time in Kuwait, and I'm looking forward to subsequent visits. I wanted to just spend a few minutes talking with you today about a relatively new concept that might be happening informally, but we chose to try and study this and bring some systematization to the issue, and that is active surveillance of distal hypospadias. So I'm going to try and cover 3 brief areas for you, review the surgical indications for distal hypospadias in the context of growing controversies around genital surgery in children, summarize some recent hypospadiologist survey data on preoperative decision-making for distal hypospadias, and finally understand the concept of active surveillance as it applies to distal hypospadias. I have just one disclosure. So by way of background, you probably know that historically all distal hypospadias has always been surgically corrected. It was first by plastic surgeons, and then more recently in the last 70 to 80 years when pediatric urology came into being, is exclusively treated by pediatric urologists today. Prior to magnification and fine sutures, the youngest patients were actually quite a bit older, 5 to 7 years old. And then as innovations in surgery evolved, the accepted window for operating on hypospadias in general was 6 to 18 months. But it's probably important to realize that there's no actual good data to suggest that 16 to 18 months is required. This is mostly by convention. So the question to repair or not repair distal hypospadias has been around for a long time. And several expert hypospadiologists have advocated for repair in almost all cases. Snodgrass and Bush and his followers have long advocated that distal hypospadias is not a cosmetic operation. They did some patient-reported outcome studies and showed that 37 to almost 2/3 of unoperated patients were dissatisfied with voiding. And there have been similar studies that have looked at children in the 8 to 10 to 11-year range and showed that they also are either unhappy or were having voiding difficulties without having had reconstruction. Conversely, however, there also are reports of many patients who are completely satisfied or even oblivious to the fact that they have distal hypospadias. In the previous study I just showed you, if you reverse the numbers, if 37 to 67% were dissatisfied, then the remaining 63 to 33% were completely satisfied with their anatomy. In a different study of 500 men, coronal and subcoronal hypospadias patients were completely unaware they had the condition at all. So given the possibility of underreporting bias in unoperated patients, it's likely that many satisfied individuals with unoperated distal hypospadias are out there. But we're not building a case to leave all distal hypospadias patients unoperated. That's not what we're saying. And it would help to sort of view hypospadias indications from a functional point of view. There are two basic penile functions. One is to create painless voiding with a single straight stream without any splaying or spraying, and to have a meatus that's distal enough and a penis straight enough for natural penetrative reproductive function. Now, almost all distal hypospadias already meets these functional criteria, but there is an exception, and that is what we call the pinpoint distal meatus subtype. These patients can have obstructive voiding when older if not corrected, and so this clearly does satisfy a surgical indication. So given that almost all distal hypospadias already meets normal functional criteria and only an aesthetic question remains, and the future potential for aesthetic satisfaction or dissatisfaction cannot be known in infancy, the real question is whether or not to repair distal hypospadias in infancy or later in life. Now, just to review the growing controversy in infant genital surgery, taking lessons from CAH, most of you probably now know that feminizing genitaloplasty surgery for virilized girls in CAH is largely on hold to a greater or lesser extent until the patients are allowed to become older. This is the case in Boston, in Chicago, and to some extent with us in Toronto. And the reasons for this are realizing that there's no functional consequence to leaving infants with these conditions unoperated initially. They're beginning to appreciate the infant's rights to autonomy and self-determination when older of what's done to them, when only an aesthetic question remains. And you can't know in infancy what a child, when they're older, might want. So the question of aesthetic non-functional genital surgery in infancy for distal hypospadias is precariously similar to this point. So to probe this a little bit further, we conducted a survey of hypospadiologists and asked them about their preoperative management thoughts around distal hypospadias. And I'd like to take a moment to acknowledge Dr. Didan Al-Shamiri, whom you just heard from, and Priyank Yadav, one of our moderators today, who were recently fellows with us, who helped collate and analyze much of this data. This was done globally through largely the ESPU and the Society for Pediatric Urology, as well as some respondents from South America and India. We looked at training level, the number of hypospadias operated annually, the perception of real-world complication rates, and the perception of complication publication bias. And we asked respondents to rank importance of physiologic factors, such as the shape of the stream, the foreskin, the meatus, and the importance of non-physiologic factors, such as emerging or established patient autonomy, the anamnestic response to surgery, et cetera. We asked them to consider these two forms of hypospadias, particularly the one in green on the left is the one they were to think about, this subcoronal variety, and to exclude the pinpoint meatus variety I mentioned earlier in their answering. So just to show you, it was a fairly responded survey. 550 people were contacted, and we had a response rate of 63%, which is considered very strong in a survey of this nature. 77% were fellowship trained. About 2/3, as you can see, operated on a reasonable or high number of distal hypospadias cases annually. Half of the respondents had published on the subject of hypospadias in the last 10 years, and this just shows you the global distribution of the respondents, that most of them were fellowship trained, either in pediatric general surgery or in urology. When we asked what you thought the real-world distal hypospadias complication rate was, not your own rate, we saw that 59% think that the distal complication, the complication rate for this form of hypospadias was in the 10 to 20% range, and another 10% thought it was even higher than that. And this is to be remembered in the context that most of the published rates are just single-digit percentages. Do you believe there is a publication bias in reporting distal hypospadias complications? And 89% of these individuals said yes, they did. So there's a marked disparity between the published and perceived complication rates in distal hypospadias, with an overwhelming perception that these issues are underreported. And this has implications for risk-benefit discussions with patients and families, especially in surgery that's being done solely for aesthetic reasons. Very long-term follow-up reveals that there are complications in adults operated as infants, and in one study, 20 to 40% of infants who were operated for distal hypospadias at less than a year of age revealed complications when they were adults. Counseling recommendations were interesting. The respondents were divided themselves essentially into three groups. 22% solely recommended surgery for this condition, but an interesting 3/4 are now discussing both surgery and observation for distal hypospadias, and a small proportion observation only. So a large majority are discussing both of these options today, which is a shift away from the de facto surgery, even for glandular and the mildest forms of hypospadias that were seen just a decade ago. When we looked at physiologic factors and how they figured in importance, it was interesting. There was no consensus on most of the, in terms of importance, on most of these physiologic factors, which we actually found surprising. There was an exception with the location of the meatus was ranked of high importance by the reconstruction and surgery versus observation groups, and the urinary stream by the observation group only. So this suggests that distal hypospadias is being operated by most people largely for aesthetic reasons, similar to what's going on with feminizing genitoplasty. In terms of the non-physiologic factors, there was high importance placed on emerging autonomy and full autonomy by the surgery versus observation group and the observation only group, and this was of low importance to the reconstruction group only. And this suggests a more patient-centric focus for these for people taking this position, which fits with the current medical paradigm of patient-centric care in most conditions. Parental desires and technical ease were rated higher by the reconstruction group, revealing a more surgeon-centric role by these groups. And interestingly, no one thought this idea of the anamnestic response, which means not remembering the surgery when you're very young, was important at all. So how to observe? There's no debate that a subset of operated distal hypospadias patients, as we know them today, are dissatisfied. However, this probably represents a failure of the practitioner to follow unoperated distal hypospadias patients. Many unoperated patients exist who don't have any subjective physical or functional abnormalities at all. And this is, as I said earlier, likely underreported as well. If you take some examples from oncology, high-risk cancer groups, there's obviously a risk of waiting and intervening, and curative or even prophylactic surgery exists for these kinds of groups. We even do that for gonadal tumor risk in children. But in the case of low or very low risk cancer, there's a risk of overtreatment and little risk of waiting. However, you don't see anybody say this: come back if your prostate cancer progresses. This is not what we're saying, and nobody would take this position. Rather, the idea of active surveillance, regular, scheduled, provider-based observation using systematic follow-up metrics, was developed. And most of you are familiar with this from the cancer world. So high-risk cancer is analogous in the hypospadias world to proximal hypospadias, and these both have surgical indications. But very low-risk cancer in distal hypospadias may be amenable to an active surveillance paradigm. So what are the features of this for distal hypospadias? It partners the patient and their family with their hypospadiologist. It allows you to monitor urine stream characteristics and development of any symptoms. You learn the boy's developing penile perceptions, his shifting desires, and the patient's own surgical readiness. This is prospective follow-up observationally by the surgeon. The metrics that we're developing are here in the table, asking patients and their families as the patients are growing, is the penis straight with an erection? Is there usually a straight or strong stream? Does the urine show any double stream or spray? These are all binary questions with a yes-no answer. Is there anything about your penis you would want to be different for the children that are starting to appreciate this? The age required for patient input is not known, but anecdotally we know patients as young as 3 years old can start to form an opinion on some of these answers, and this will vary, and that's okay. And responses may change over time, and that's okay as well. That's the very nature of this kind of surveillance. But the patient is able to contribute to their own distal hypospadias conversation. And we're trying to develop these to build them into our electronic medical record, and these questions can be administered that way without necessarily bringing patients and families in for a visit. So in summary, some distal hypospadias does harbor functional abnormality, and there are surgical indications just as there are for proximal hypospadias. There's a surprising lack of consensus on surgical indications for distal hypospadias, especially with regard to physiologic factors, which we found surprising. And it tends to support the conclusion that this form of hypospadias is being operated largely for aesthetic reasons. And if we don't continue to address this as we're doing today, this is going to create tension in the field. We need standardized guidelines for pre-op discussions. We need systematic outcome data transparency and very long-term follow-up for distal hypospadias complications, which are probably underreported. And follow-up beyond the pediatric institutional time limits. At our institution, it's 18 years old. And we need follow-up for this condition beyond that in a systematic way. Hypospadiologists' contemporary attitudes are changing. Patient preferences and autonomy are becoming prime considerations in distal hypospadias, and that's true in all healthcare, and there's no reason that this entity should be any different. Surgery and observation discussions are now prevailing initially in infancy, and simple active surveillance as a guide by the hypospadiologist has been summarized, as I showed you earlier. And finally, I'll just conclude by saying that circumcision per se in distal hypospadias discussions is unexplored in this information thus far, and it's probably a co-founder in some of these preoperative management discussions. So I think with that, I'll just conclude that distal hypospadias surgery is becoming more a question of when and not necessarily a question of if. Thank you very much.
Thank you, Dr. Bagley. With that, we come to the final presentation. Dr. Ahmad Hamadi, if you can come, please. And the topic is secondary PUJ obstruction, surgical or laparoscopic.
Thank you, Mr. Chairman. Hi, everybody. My presentation today is about the secondary PUJ and whether we can manage it in surgical or laparoscopic base. So we will find out. There is nothing to disclose. First of all, we need to define what do we know about the secondary or failed UBGO surgery. If we can decide if it is a problem and we are facing it, and sometimes we know that the incidence of the failed pyeloplasty in open surgery was reported to be more than 10%. While the failure rate after laparoscopic pyeloplasty is about from 2 to 16%. So what's the secondary or the failed pyeloplasty? We need to know what is the proper define, how to ensure our diagnosis, how long to wait until to intervene actively for the management, what's the role of the experience in choosing the best options for treating. So surgical success was defined as symptoms resolution, unless the patient is asymptomatic, anteroposterior diameter to be decreased, pelvic and calyceal tension decrease in renal ultrasound. The ureter could be seen within the 40 minutes in the IVB. No change on the renal cortical thickness, and the post-operative T-half improved during the follow-up. So do we have a post-primary surgery follow-up plan? Actually, this is the question should we ask ourselves first, but you should know that there is no consensus on the standard guideline for the post-surgical follow-up that leads to much heterogeneity in the length of the follow-up and the type of imaging among the urologists. All this in the publication ask the same question. How and when I can judge that I have a failed case of pyeloplasty, or to ensure that it is a successful operation. So remember that a minimum of 3 years of follow-up is necessary to detect the majority of the recurrent obstructions. So what type of investigations you need to confirm the obstruction of patient after previous pyeloplasty? Nothing of those that I will mention now can use alone. You need to have an ultrasound to find out the degree of obstruction, diuretic renogram using DITBA or MAC3, IVB, or you can use instead the contrast enhanced CT. Although the diagnostic criteria of defining the failure of pyeloplasty are not well defined. So I like to present this paper because it actually gave us the idea about the haziness of the diagnosis, when and where and how. So after the repair of the BUG obstruction, there is an hydronephrosis. So the question here is hydronephrosis after pyeloplasty, will it go away or not? So it quoted from Ricard in 2016, his saying of the greater than 20% improvement of anteroposterior diameter of renal pelvis after pyeloplasty is indicative of resolution of obstruction. Although the conclusion of this question was the complete resolution of hydronephrosis is uncommon and unpredictable. So all caregivers should be counseled to expect dilatation to persist after obstruction is corrected. So definition of failure. Now we have defined the success. Now you should have also define the failure. Persistent or increasing the pelvic dilatation, diuretic renogram persisting, giving results of persistence of obstruction pattern. Also, the patient is complaining of flank pain, recurrent febrile infection, or infected hydronephrosis with subsequent PCN. So one of them actually is enough to diagnose a failed case. So we have to choose the patient carefully, that the patient has a failed pyeloplasty. What's my option and which technique I can use? So the options are either you can use a temporarized approach by placing a double J stent until you define your plan for the repair, or you go directly to a definitive approach, which could be redo open pyeloplasty, balloon dilatation, antegrade or retrograde endopilotomy, laparoscopic redo, robotic assisted, ureterocalicostomy, or finally by nephrectomy if the kidney is not functioning well. When we look at this systemic review and the meta-analysis for open versus laparoscopic and robotic, in this meta-analysis, it included 18 articles, including 87 and 77 and 123 redo-pyeloplasty who were submitted to open surgery, laparoscopic surgery, and robotic surgery. And the overall success was actually comparable to each other, but the laparoscopic had a significantly shorter hospital stay than the open surgery, and the complication of both open and laparoscopy was 9%, with the conclusion that the minimally invasive techniques seems to have to be a good alternative to open surgery for the redo-pyeloplasty in children with comparable success and complication. Although we can, after we discussed what is internally, including the results, also the cosmetic part is important. So the comparison of cosmetic results in children more than 10 years old undergoing laparoscopic and open and robotic pyeloplasty, the conclusion of this article, what's important for me is that the open pyeloplasty was more commonly associated with scar-related symptoms and the size of incision parallel to body mass index. That means we want to go to the minimal invasive rather than putting morbidity to the child to repair the pyeloplasty. So is there a chance for the endopylotomy? Actually, most of the publication after years of using the endopylotomy concluded that the outcome of the pyeloplasty with the endopylotomy is less than what you can do it with laparoscopy. So now we have the laparoscopy as an alternative to open surgery. So a lot of publication comparing the results of laparoscopy with other method in treating the secondary BUG, and most of the concluded that the laparoscopy pyeloplasty is safe and viable treatment with good results comparable to even the open surgery. The operative technique is usually transperitoneal, and it's like the primary cases. Retrograde pyelogram, the patient is placed on lateral decapitous position using three ports technique, and according to the age of the patient, so you can adjust the size of the trocars. So what we have here is a case of secondary BUG on the left side. I tried to give a short video about what you will face during this maneuver, which needs an experience to run or to anticipate a good result. As you can see, that most of it's adhesions all over the BUG area. Mostly you have to have a blunt and sharp dissection and try to avoid the use of whatever energy source to preserve the vascularity of the BUG. Tough tissue you will be faced. So good instrument is mandatory with good experience, and a good experience in pyeloplasty itself. So you can judge whatever the technique you are using, either dismembered or other techniques. Once you have do the pyeloplasty Anderson-Hines, then you should explore also what's inside the pelvis, because sometimes you can find the secondary stones inside, and then the suturing technique is most important. To be familiar with it and to avoid the twisting of the BUG, and otherwise we will compromise the vasculature. So what's the etiology based on the operative finding of this secondary BUG? Mostly it's pelvic fibrosis, and it's coming from the previous operation. Missed lower pool crossing vessel, and this is the advantage of using laparoscopy in this management, because the visibility is much better. Short proximal ureteric structure, a kink and the UBG associated with redundant pelvis, poorly positioned anastomotic stoma, or diabetes in some times. This is a comparison we have done between the patient submitted to a primary and second laparoscopic pyeloplasty, and the results was actually, maybe yes, it's longer in the operative time, but the result is actually comparable between the primary and the second laparoscopic pyeloplasty. Those are also publications from the literature, and most of it, the results ranging from 77 to 90%. So why laparoscopy? At the end, the pros will reproduce the open surgery. It's minimally invasive, high success rate, and no ugly scar. What is difficult in sometimes, it's a transperitoneal with the risk of injury of internal organs, the longer operative time, and needs a good laparoscopic experience. So the conclusion here, this is a failure of very effective procedure as Henderson-Hines or a pyeloplasty is extremely rare in experience at hand, but it could happen. So follow-up plan after the primary operation should be periodic unless the patient becomes symptomatized. Selection of patient for redo pyeloplasty should be confirmed in the follow-up by diuretic, renogram, IVP, or CT with contrast. Laparoscopic pyeloplasty is feasible and effective procedure for the treatment of recurrent BUG with low rate of post-operative complication and high success rate. Other than longer operative time, laparoscopic pyeloplasty is comparable with laparoscopic management of primary BUG. And thank you very much.
Thank you, Dr. Hamadi. So the session is open for questions from any of the previous 5 talks. If anyone has a comment or a question we'd like to have.
So Dr. Yusuf, please, Dr. Yusuf Al-Halaq. Dr. Daidan, can I ask you please a question about when do you intervene in VUR children, either endoscopically or surgically?
Hi, thank you for the question. So basically when there is a failure of antibiotic prophylaxis, when there are breakthrough febrile urinary tract infections, and I see, so in these patients, I am more inclined to offer surgery just to protect the kidneys. And again, I am a type of person that would like to start with the deflux injection prior to any reimplants. And I did see success even with high grades of reflux with deflux injections. Sometimes the first deflux injection reduces the severity of the reflux, and the subsequent actually deflux injection takes care of it. However, as soon as the patient is more than 1 year old and is having recurrent breakthrough UTIs despite being on prophylaxis, I would definitely think about offering surgical option.
Do you put renal scars as one of the indications if you do a DMSA?
So yes, I think also in the European guidelines, renal scar prompts surgical indication. So definitely above 1 year old, and the existence of renal scar and failure of antibiotic prophylaxis definitely prompts me to offer surgery.
Thank you. Questions for Dr. Walid Isa? Any questions for Dr. Walid?
When we are doing a redo pyeloplasty, is it easier to do it laparoscopically when the initial procedure was open and vice versa? And second question is, in the redo pyeloplasties in giant hydronephrosis, what is the expert's experience in plication or folding procedures?
This is for Dr. Ahmed. Dr. Ahmed Hamadi.
Thank you for the very nice question, actually. Thank you. To explain that we have interest in such operation, which is actually, it is rare and sometimes you can, yes, and we can say it's 10% of the failed results from the open pyeloplasty or laparoscopic. There is a 10% rate of failure. But when you are facing it, you have to decide to touch the child or the patient or not. As I've said, it is not an easy operation. It's hell sometimes. It's adhesions everywhere sometimes, and sometimes it's so easy. So this decision when to intervene, this is the most important. Then you can say my experience is enough to do it laparoscopically or not. Otherwise, you can do it open. I'm not pushing towards the laparoscopy, because the most important is the safety of the patient. So if you are not able to do it laparoscopy and you can do it open, so it's okay. But the point is, it is a very difficult operation, but and need a good experience to be able to do the same what you are doing, the same steps in easy way, but in the field is not that good in most of the time. So the adhesions is the most difficult part. The other point is never use any energy source near the BOG. This is the most important, because you will not be happy once you are dissecting everything using the diathermy or something like this, or whatever the source, and then you have the another BOG obstruction.
Thank you.
Thank you. I'll just share our experience. As I said, our experience is, sir, that whenever an open procedure is done, then if you do a transperitoneal procedure, that is laparoscopic or robotic, it is slightly easier than going through the same route which is violated. If somebody insists on a second minimal access procedure, then asking him for a robot is a better option than laparoscopy, if the previous procedure was laparoscopic. That also gives you an option if just in case you need to do a ureterocalicostomy, you will be slightly in a better position. So this is our institutional experience, sir.
Yeah.
Thank you.
Thank you. And just to add to that, there are two types of giant hydronephrosis that we all as pediatric urologists would see. One has a very large extra renal component where the pelvis is flappy and you can do plication, reduction, whatever in the world you want, you'll be able to do it easily. The second one has a megacalicosis more than an extra renal pelvis. Now, the second variety of megacalicosis is actually dangerous in a way that if you do a standard pyeloplasty in a big kidney, let us say 10 centimeter kidney, papary thin parenchyma, and the extra renal component is not huge, many of them don't drain well. And it is these, when you go in with a plan for a redo procedure, you do it lap or open, you see the pelvis is not in a dependent position and you end up doing a ureterocalicostomy. Sometimes rather than doing an end-to-end ureterocalicostomy on the ureter, make two incisions, one on the ureter, one on the lower part of the pelvis, and do a side-to-side without maybe dismembering the UP junction. So you don't need to dissect on that. The important thing in this case is when you're dealing with reoperations, sometimes in addition to the ultrasound, a cross-sectional imaging, sometimes CT or even MRI can help to give you an idea about what the anatomy is, because once you are in, there are only limited things you can do. As kids grow older, especially beyond the age of 4 and 5 years, doing an open redo procedure has its own challenges in terms of incision size, as we have already seen. And the other thing is, in order to do a ureterocalicostomy or even a redo pyeloplasty, for an open surgery, we need to do a lot of mobilization, bring everything up to the surface almost, in order to be able to suture comfortably. So there, laparoscopy or robotic surgery actually has a very good advantage because everything stays down, there is no significant traction, and we have a lot of mobility. We can mobilize the kidney laparoscopically, robotically, with I think similar ease. So that is one thing that must be kept in mind. So preoperative planning is vital, it's paramount in cases of a redo pyeloplasty.
Sorry, Dr. Adab, I have a question to yourself and maybe Dr. Ahmed. In the cases, and also Dr. Akram, in the cases of redo pyeloplasties, if the retrograde pyelogram shows drainage, shows complete drainage, as you put contrast, it drains very easily. However, we do have either an obstructive pattern on the Lasix scan, or we also have worsening ultrasound. This represents a dilemma, a draining retrograde. What do we do in this case? What's your experience? Also, Dr. Ahmed, also anybody in the floor, what's the experience?
Yeah, so we just published last year in the Journal of Pediatric Urology the same dilemma that you talked about, where giant hydronephrosis in follow-up poses great challenges because it is one population which will almost always show hydronephrosis months to even years down the line. So a lot of things have to be seen, and it's a like few different things you see together. So the percentage function cortical thickness, overall kidney size, patient symptoms, all of that has to be taken into account. Now, what happens is once you have relieved the obstruction, you've done a good surgery, so with time you will see the kidney size, the pole to pole length, it starts decreasing. Cortical thickness may or may not improve. The split function, it is, I would say, the most unreliable parameter in that case, because a lot of these giant hydronephrosis have overestimated function. So you may have a kidney that has a supranormal function, 55%, sometimes even 60% before surgery. You do a surgery, the kidney becomes smaller, everything is now nice and clean, and the function goes down to 25 to 30%. And now there is a question, so is this the real function which was overestimated pre-op or not? So one criteria in a redo or in a giant hydronephrosis in a massively dilated kidney is not enough. Sometimes the only thing that might guide you is, relief of symptoms. Every other criteria, pre-op, post-op drainage remains the same. We've got to remember when we do a LASIK scan, they do a 20-minute observation, right? So it's only those 20 minutes. If the kidney fills and it empties, then they say, okay, it's not obstructive drainage. People have tried doing an F+20 study where you give the LASIK after you have administered the radionuclide, so that comes into the pelvis, and now there is a push by the LASIK, so then it starts draining. So that is one thing you can actually discuss with the nuclear medicine guys to explore in that specific population. And Dr. Hamadi.
And my point is, when you have an imaging, which is a retrograde, as you said, and there is drainage, and when you are doing a renal scan, it's an obstructive. This is the question, yes? So a dynamic renal scan is important. Symptomatology is very important in this point. Is there a pain? Is it an infection or whatever the symptom that can come with the obstruction? I think you will not be able to jump to a decision at once. Maybe if we can take that's like a lab break. It's a follow-up. Let's follow up the patient for even a month or two, and we will see if it is progressive, if symptoms is coming up. I think this is the point of obstruction. If not, I think it is draining. Sometimes there is a fallacies in the renal scan. Sometimes. So you cannot judge 100% because the radiologist cannot give you what you need, or this is inefficient in the diagnosis. So for myself, the symptoms is very important. Ultrasound follow-up, you cannot put the patient in another operation, especially the pyeloplasty, unless you are at least mostly sure that it is an obstructive and it will deteriorate the renal function. Otherwise, I think follow-up is very wise.
We are running out of time, but I have only last question for Dr. Bagley. That's a very sensitive issue in many indications, and it's also subject to different cultures. Because I have, in my own personal experience, many adults coming for repair of distal hypospadias because they are married, they have children, but they are not psychologically satisfied. I have many parents that after repairing their children's hypospadias, they told me they have the same thing and they didn't like their children to be the same. And we have the question, why don't we wait for children to ask them if they need to repair a lip notch or a preauricular tag or an accessory finger. That's what I say. It still needs a lot of research in different cultures and over a lot of time.
Thank you very much. What was exactly the question?
The question is the question of leaving a hypospadias for a child to grow up and decide needs a lot of investigation in different cultures. As in the same sense, we don't ask a child if we will repair his lip notch or his accessory finger or preauricular tag. This is what I'm asking. And all they are all done for aesthetic and psychological indications, not for functional indications.
Right, I agree. It is a complex issue. There's going to be some degree of cultural variation that has to be taken into account. And I think what we're going after here is the idea that each case be followed closely by the practitioner with the family, and not to simply jump into the decision early on, to try and allow for some degree of input from the patient. One is not talking about, as I say to parents, waiting for children to grow up and sign a consent form. We're not talking about that. We just want to get some idea which way they may be leaning, because that's in 2023, 2024, and the whole idea of genital surgery in children, this is becoming something that we need to responsibly take a hold of and try and factor into this decision-making process. If you go back 10 or 20 years, all distal hypospadias was just repaired without any question. And we're trying to actually do the right thing and and try to bring some modern consideration around the patient to this question. An example I can give you was the very last thing I mentioned in the presentation, was the whole idea around circumcision. Circumcision is a very difficult thing to talk about when you're trying to talk about hypospadias, and I deliberately leave that out of the conversation. And I tell parents that if this is something that they want, this is a thousands-of-year-old question, circumcision. It's far too big for any surgical specialty to become expert in. I tell them that if this is something they want, it will happen. It may just be delayed. So then they understand that what they really want to have happen will happen. It's a matter of time shifting here more than anything else. It's not a question of not doing something.
Thank you. And thank you all. By this, we come to the end of our session. We thank all the speakers, all the attendants for bearing to the end, and thank you very much.